Hello everyone. Today we'll be discussing the Iota approach to adnexal masses. Now, adnexal masses can be ovarian or non-ovarian in origin. That is, they can arise from other adnexal structures, for instance, the fallopian tubes or the peritoneum. Whenever we see an adnexal mass, the first thing that we need to do in order to understand how to manage that mass further is to identify as to whether it is benign or malignant. Now, when we see an adnexal mass, the implications or the likelihood of it being benign or malignant depends on the age and clinical features with which the patient presents. For example, if the lady is in the premenopausal age group, then a large number of adnexal masses that we see in this age group are actually benign and borderline ovarian tumors, and the number of invasive ovarian cancers seen in this age group is relatively low. On the other hand, when we see an adnexal mass in a postmenopausal woman, one can identify from this diagram is that invasive ovarian cancers constitute a significant chunk of malignant adnexal masses, and hence, in a postmenopausal woman, must be given due consideration. However, still the number of benign ovarian lesions outnumber invasive cancers, but as compared to premenopausal women, postmenopausal women have got a higher risk of an adnexal mass being a malignant ovarian neoplasm. Now, these are common adnexal masses that one can come across in our day-to-day practice, and irrespective of where we live on this planet, all of us should use a standardized terminology to describe these masses so that when we take appropriate management actions, they are uniform. When one sees an adnexal mass, the pelvic ultrasound report should have a comprehensive description of this adnexal mass. And once the mass is described, one has to look for other associated findings, which can be seen in malignant ovarian tumors like ascites, lymph nodes, peritoneal deposits, and involvement of solid organs like liver, spleen, kidney, etc. Once we've done that, we need to characterize as to whether the mass is benign or malignant, or if it is inconclusive based on our findings. And once we've decided what the mass is, we suggest further management action. Now, the Iota, or the International Ovarian Tumor Analysis Group, came up with a standardized terminology to describe adnexal masses more than 2 decades ago. And these are the terms and definitions and the techniques of measurements that we should use when describing adnexal masses so that all of us speak the same language. As I said, the advantage of using the Iota terms and definitions is that all of us understand each other because we use similar language. It helps in accurate preoperative discrimination of a benign and malignant adnexal mass. There are risk prediction models, that is, based on certain characteristics of the patient as well as the adnexal mass, we can calculate patient-specific risk of having a benign, borderline, or malignant ovarian tumor. And this can be done by using models like ADNEX, which are available not only as a web application, but also on our mobile phones, as well as it is incorporated in some ultrasound machines as well. The advantage of using the same terminology is not only in that we can serve our patients better, but also we can study the long-term behavior of masses which are managed expectantly, that is, without doing any kind of intervention. We can do research involving use of novel biomarkers to investigate adnexal masses. Now let us come to the various terms which have been proposed by the Iota group. First is the term lesion. Now, what is lesion? Lesion is defined as the part of an ovary which is inconsistent with normal physiology. So if we see something which is not consistent with normal physiology in an ovary, it is described as being a lesion. Now, what do we see here? This is a corpus luteal cyst. It is a unilocular lesion. It has got ground glass internal contents, and this bizarre shaped echogenic content is nothing but a clot. If I would push upon this with a transducer, it would move, suggestive of being a clot and not a solid component. And also on switching on color Doppler, we can see the peripheral vascularity, which is seen in case of a corpus luteum. Now, we all know that corpus luteum and the consequent corpus luteal cyst are a part of normal physiology, And that is why a corpus luteal cyst in an ovary will not be termed as a lesion. So whenever we see a mass in the adnexa, based on its appearance, we can characterize it as being unilocular, unilocular solid, multilocular, multilocular solid, and solid. If the lesion is a cyst, then we need to see its contents and describe them, which may be all black, that is anechoic, low level echogenic, ground glass, hemorrhagic, or mixed. Then we'll need to look at the cyst wall on its inner side, and this cyst wall can be smooth or regular, or it can be irregular due to presence of solid components. What is a papillary projection? A papillary projection is a solid component seen in the wall of a cyst. It protrudes into the cyst cavity, and it should have a height of at least 3 millimeters or more to be called as a papillary projection. If its height is less than 3 millimeters, it is termed as wall irregularity. And please remember that papillary projection is a solid component. So if there is a cyst with a papillary projection, if the cyst is unilocular, it will be termed as a unilocular solid lesion because of the presence of papillary projection, which is considered as a solid component. Then when we see solid components, we need to look for acoustic shadowing within the solid component and also behind the solid component, because sometimes we see shadows within the lesion and at other times behind the lesion. And of course, we can switch on color Doppler to assess the color score. Now coming to the description of the appearance of various adnexal lesions. Unilocular cyst, as the name suggests, has a single locule. It does not have any complete septation or a solid papillary projection within it. So as you can see in all these three images, they are all examples of a unilocular, that is a lesion with a single locule. Now here you might think that you see multiple locules, but please remember there is no complete septation. You can see that this septum is incomplete. A septum is said to be complete when it extends from one wall of the cyst to the diametrically opposite wall, which is not happening here. So this is an incomplete septation, as we see often in hydrosalpinges, and hence this lesion will be termed as unilocular and not multilocular because the septae are incomplete. Another description about solid component. Now, what is solid component? I said papillary projection is a solid component. Besides papillary projection, any structure within a cyst which has high echogenicity will be termed as a solid component. But there are certain exceptions to this. The white ball, which is composed of sebum, hair, and teeth, in case of a dermoid, is not considered to be a solid component because it's not solid tissue. It is just composed of sebum, hair, and teeth. So please do not characterize the white ball of dermoid as a solid component. Also, the blood clot, just as we saw within the corpus luteal cyst, is not a solid component. So corpus luteal cyst is not a lesion, and the clot within it is not a solid component. How do we differentiate a clot? As I've described in my earlier videos, we use the dynamic real-time imaging ability of ultrasound and gently press upon the cyst with a transducer. A clot, because it's not hard, it's soft, jelly-like, will move when we probe the lesion with our transducer, or when we push the lesion with our ultrasound transducer, whereas a solid component will not move. Also, if we switch on color Doppler and there is presence of vascularity, we can be sure that the lesion is solid because solid lesions can show vascularity. However, remember, if the lesion does not show vascularity, it does not mean that it cannot be a solid component. It can still be a solid component. Sometimes we may not be able to get color because of technical reasons. When the solid part is very far away from the probe, then the Doppler signals may not be picked up. Or sometimes the vascularity may be so low that it may not be picked up by our ultrasound probe. Or really, if we are not aware of the correct machine settings and our settings are not right, then we may not see vascularity. So presence of vascularity makes us sure that a lesion is solid. However, based on the absence of vascularity, we cannot be sure that a lesion is solid or not. So there can be solid lesions without picking up vascularity on Doppler. If you have doubt as to whether a lesion is solid or not, it's always better to err on the side of caution and label the lesion as being solid. As I said earlier, this is how a clot looks like. You can appreciate these are both examples of hemorrhagic cysts, both of which are being pushed by the ultrasound probe, and we can see the contents. These are the fibrin strands, and this is the clot seen within this hemorrhagic cyst, which is moving freely on applying gentle transducer pressure. So we know that these are just clots and not septae or solid components. As I said earlier, if it were to be a true septum, the septum has to extend from one cyst wall to the opposite, and none of the so-called strands here seen in this image are extending from one cyst wall to the opposite. So these are not septae. This is just a unilocular hemorrhagic cyst. Do not make the mistake of calling it multilocular. This is a unilocular hemorrhagic cyst, and this is a unilocular hemorrhagic cyst as well. Do not mistake this for a solid component and label this lesion as being unilocular solid. As I said earlier, we can use color Doppler. In this case, we've switched on color Doppler, and how it has helped is that we can see this peripheral vascularity, which is characteristic of the corpus luteum. So this is a corpus luteal cyst. Just based on the absence of vascularity within the lesion, please remember we cannot totally exclude the possibility of the echogenic component not being solid. As I said earlier, we understand what a papillary projection is. It is a solid protrusion into the cyst cavity with a height of 3 millimeters or more, and it is considered to be a solid component. When its height is less than 3 millimeters, it is termed as irregularity. Again, to stress, what is septum? It is a thin strand of tissue which runs from one cyst surface to the other. Incomplete septum is something which is not seen reaching from one internal surface to the other in some scanning plane, as we see in case of hydrosalpinx. So it's important that whenever we see a septum or a thin linear strand within a structure in one plane, we turn our probe and try to sample or try to see the lesion from multiple planes or multiple angles so as to exclude or look for whether it is complete or incomplete. So just scanning a septum in one plane is not enough. As is the principle in imaging, we must scan the lesion at least in 2 planes. And when we see a septum, try to see it in multiple planes to see whether it is complete or incomplete, because that is based on whether it is complete or incomplete, our appearance of the lesion is going to differ. As you can see here, this is a hydrosalpinx with a characteristic incomplete septation within it. So this lesion will be termed as unilocular. Coming to unilocular solid. Now, as the name suggests, the lesion will be unilocular with some solid component within it, which can be measured. The papillary projection, even if a single papillary projection is present in a unilocular cyst, it will be termed as unilocular solid. As you can see here the dark part represents the fluid component, whereas remember the solid component has high echogenicity, so the white part represents the solid component. You can see there are these 3 lesions. All of them have got solid component here, here, and here, but they are unilocular. They have a single locule, so they will be termed as unilocular solid. Coming to multilocular cyst. Now, a cyst which will have at least one complete septation will be multilocular, and this should not have any measurable solid component. So, no solid component should be greater than or equal to 3 millimeters, because otherwise it will become a papillary projection and then the lesion would become multilocular solid. So multilocular should have one complete septation and no solid component, as you see in these illustrations as well as in the lesions below. So you can see there are multiple septations. This is the entire lesion, and here you see one septation which is going from one cyst wall to the other. It is complete. So this is multilocular, multilocular lesion again, multilocular. Remember, we have to ensure that the septum is not incomplete in any plane. Here we are just seeing one plane, but of course we've seen it in more than one plane and ensured that the septum is not incomplete. As we said earlier, septum is a thin echogenic strand of tissue running across the cyst from one internal surface to the contralateral side. Then after multilocular, we move to multilocular solid. So in multilocular, if you add the solid component, as you see here, as well as in these ultrasound images, there are presence of multiple solid components within this multilocular lesion. So when there are measurable solid components in a multilocular lesion, it is termed as multilocular solid. And finally, the solid tumor. Solid tumor is a tumor which comprises of at least 80% or more of solid component in a two-dimensional section. As you see here, this is one image of 3 different lesions. This is completely solid. This one has some cystic component, but you can see in both these lesions which have some cystic component, the solid part comprises 80% or even more of the lesion, and hence these lesions will be termed as solid lesions. Now, if you see a cyst, besides seeing its appearance and describing it in terms of being unilocular, unilocular solid, multilocular, or multilocular solid, next that you need to see is its contents and identify the echogenicity of the contents. As I said earlier, if the contents are completely black, it is termed as anechoic, and anechoic appearance is typically seen in follicular cysts or serous cyst adenomas, as seen here. This is what we call as the ground glass appearance of cyst contents, which is characteristic of an endometrioma. We've seen this lesion earlier. This is the hemorrhagic contents seen in a hemorrhagic cyst. When we push upon the cyst with the probe, these contents move. These are not complete septations, as we've discussed earlier. This is what the presence of these tiny echogenic specks within this cyst with on a black background is what we call as presence of low-level echoes. So this low-level echogenic contents are characteristically seen in mucinous tumors of the ovary. And finally, these are, as the name suggests, a cyst with mixed echogenic contents. So there are certain areas which are totally anechoic, certain which are echogenic, others which are ground glass kinds. So this kind of appearance is mixed echogenicity. Remember, do not think that this echogenicity is because of hemorrhage. Dermoid cysts do not show hemorrhage within them. This is just because of difference in the turbidity of contents that this area of the cyst has got ground glass kind of appearance, but this is not because of hemorrhage within dermoid cyst. So this is what we call as mixed echogenicity. We at least see 3 different shades of gray ranging from black to white, and these are the mixed echogenic contents which are hallmark of dermoid cysts. So we've looked at the appearance of the lesion. We've looked at the echogenicity of its internal contents. Another thing that we need to look for is the presence of acoustic shadowing. So we look for acoustic shadowing within the lesion, and here you can see presence of this dense acoustic shadowing posterior to the echogenic component of a dermoid cyst. Remember, this echogenic component will not be termed as solid, so this lesion will just be unilocular. Then let's have a look at this lesion. First, based on its appearance, it is a solid lesion. And of course, we can see presence of shadows within this lesion. So here we see shadowing behind the lesion, whereas here we see shadowing coming from the lesion. These are both examples of acoustic shadowing, which must be looked for in every adnexal lesion. Then we come to the cyst wall. So this is what is the inner cyst wall. So whenever we see a cyst, we must see its inner wall. As you can see here in this part, the cyst wall is regular or smooth. However, here it becomes irregular because of presence of these papillary projections. And so this would be called as a cyst with irregular inner walls. When we see a solid lesion, then what we look for is the outer surface. In a cyst, we look at the inner part of the wall, whereas in a solid lesion, as you see here, this lesion is predominantly solid. What we look for is its outer border, and we can make out that the outer border of this solid lesion, which is outlined by ascites, is irregular. So irregular border is seen in a solid lesion on the outer surface, whereas irregularity of the cyst is seen along its inner wall. Coming to vascularity, Now, based on the kind of color score that we see, we can grade the lesion as having vascularity ranging from a color score of 1 to 4. Remember, this is a subjective assessment of blood flow. So if we do not see any blood flow within a septa, the cyst wall, or the solid areas, then it is given a color score of 1. If we see minimal flow, as you see here, within a septum, solid component, or in the cyst wall, then it is given a color score of 2. Color score of 3 is moderate vascularity, seen again either within the septum, the solid component, or the cyst wall. And finally, intense or marked vascularity would be termed as color score 4. Remember, whenever you are looking for vascularity, the preset or the settings on your machine have to be the same every time. They should be adequately low with a low pulse repetitive frequency of 0.3 to 0.6 kilohertz to ensure that you are not missing out on slow flow. Now, these are examples of vascularity within an adnexal mass on power Doppler at a PRF of 0.3 and 0.6. And we can see here that this lesion shows a vascularity of at least a color score 3. However, if we were to lower the PRF further, that is, take it down to 0.1, which is a very low PRF, there would be artifactually increased vascularity. Now here you see vascularity within the lesion as well as in certain unexpected areas. For instance, the cystic part is also showing vascularity, which cannot be normal. It is artifactual because fluid cannot show vascularity. So this vascularity is not because of there being blood flow in the lesion, but because we have set the PRF to too low, and this is all artifactual vascularity which we are seeing in the fluid component of the lesion, which is not possible. And if we increase the PRF too much, as you can see, it's as high as 1.8 kilohertz here, then there would be artifactual loss of vascularity. So now we'll think that this lesion has a color score of 2, which again would be incorrect because what is the problem here is our high PRF and not abnormal vascularity. Measurement of the mass. Now, when we measure any lesion, as we understand, we have to take 3 dimensions. The 3 dimensions have to be perpendicular to each other, and so they have to be taken in 2 orthogonal planes. So once you see an adnexal mass, try to see it in its longest dimension. For instance, in this unilocular cyst with smooth walls and anechoic contents, this is the longest dimension. And here we take 2 measurements, one anterior-posterior and the other side-to-side. And to get the third measurement, all that we do is rotate the transducer 90 degrees anti-clockwise and get its third dimension by measuring the lesion from side to side. The volume is calculated just as we do in the ovaries by multiplying the 3 dimensions with 0.5, which is the formula for calculating volume of an ellipse. How do we measure a papillary projection? Now, as I said earlier, papillary projection is a solid component seen protruding into the cyst cavity, as you see here. So this is the internal contents of the cyst. This is the wall of the cyst. And this would be the papillary projection here, protruding into the cyst. So when we measure, what we do is we measure the height. While we measure the height, we must take care that we don't include the cyst wall in measurement of the height, because that would give us a falsely increased height of the papillary projection. So we just include the part which is protruding into the cavity and exclude the cyst wall while measuring the height of a papillary projection. Then we can measure the base of the papillary projection. So this is how we take 2 dimensions. And once we've taken these 2 dimensions, we just rotate our probe 90 degrees to get the second perpendicular plane and take a side-to-side measurement to get the third dimension. So we can take measurements in 3 diameters of both the adnexal lesion as well as the papillary projection or the solid component within it. Ascites is presence of free fluid in the pelvis, which extends either into the utrovesical space, that is between the uterus and the urinary bladder anteriorly, or if the fluid is significant enough when it extends above the level of the uterine fundus. So some amount of free fluid in the pouch of Douglas is seen normally in women of reproductive age group in the premenopausal age, and this should not be termed as ascites. Ascites is when you see fluid in the utrovesical space or this fluid is seen above the level of the uterine fundus. Besides coming up with certain terms to describe adnexal masses, the Iota group also has given certain simple descriptors which can help in identifying an adnexal mass as being likely benign or malignant. These are based on pattern recognition of certain obvious adnexal abnormalities. So there are 4 benign descriptors with which we can identify certain common benign masses in our day-to-day practice, and 2 malignant descriptors. So benign descriptor 1 is a unilocular lesion with ground glass echogenicity contents in a premenopausal woman. So you see here, suppose this is a 35-year-old lady. So what you see here is a unilocular lesion with ground glass contents, smooth inner cyst wall, and this is what an endometrioma looks like. Remember, this is seen in a premenopausal woman. Second benign descriptor, which is again seen in a premenopausal woman, is presence of a unilocular lesion. So you see here a unilocular lesion with mixed echogenicity, anechoic, hyperechoic, ground glass echogenicity areas, and this is what is the characteristic appearance of a dermoid or a benign cystic teratoma. So again, do not mistake this echogenic component, which is nothing but mixture of hair, sebum, as solid. This is a unilocular lesion and not unilocular solid. Coming to the third benign descriptor. So if you see a unilocular lesion with regular, that is smooth internal wall and a maximum diameter of less than 10 centimeters, then it can be termed as a cystadenoma or a simple cyst. The fourth benign descriptor is, it refers to the remaining unilocular lesions with smooth regular walls. So if you still see some unilocular lesion in the adnexa with smooth regular walls, as you see here, this is nothing but a hemorrhagic cyst. This is a unilocular lesion because you see these septae are not reaching up to the opposite wall. These are just thin echogenic fibrin strands in a hemorrhagic cyst, and this is benign descriptor 4. So benign descriptors, if you see, are typically used for unilocular adnexal lesions based on their contents and size. Malignant descriptor 1. So what feature in a mass can make you think in terms of malignancy? So malignant descriptor 1 is an adnexal lesion with ascites. We know what ascites is, and at least a color score of 3. So at least moderate or marked vascularity and presence of ascites in an adnexal lesion in a postmenopausal woman is malignant descriptor 1. Because we discussed earlier, postmenopausal women have a high risk of having malignant adnexal masses. So this is what malignant descriptor 1 is. Malignant descriptor 2 is again based on the age. So if a lady with an age of more than 50 years and a CA 125 level of more than 100 international units per ml presents to you, then the adnexal mass is likely to be malignant. Besides simple descriptors, because simple descriptors are only applicable to a certain group of adnexal lesions, we need more clues in order to classify the remaining adnexal masses as being benign or malignant. So the Iota group moved on from simple descriptors and proposed simple rules which can help in preoperative classification of an adnexal mass as being benign or malignant. The advantage is that if we can confidently say that an adnexal mass is benign, the patient's anxiety is relieved and nothing needs to be done about it. However, if there is certain suspicion about the mass, then of course we can go in for timely referral and the mass can be managed appropriately. Now, simple rules are based on 5 benign, that is B features, and 5 malignant features. You need not remember these rules by heart. You can just have a printout of these simple rules that you can keep in your OPD, by your bedside, in your clinic. And whenever you're working and come across an adnexal mass, you can just take out this proforma and see whether simple rules apply to that adnexal mass, whether B or M features are present in the adnexal mass or not. Now coming to the B rules, the rules are useful for predicting a benign tumor. So if you see at least one B or benign feature in an adnexal mass in the absence of any M or malignant feature, then the mass can be termed as being benign. What are the B simple rules? B1 is presence of a unilocular lesion. B2 is presence of solid component where the largest solid component has a largest diameter of less than 7 millimeters. Remember, in Iota, we typically describe, or the unit that is typically used while measuring either the entire lesion or its solid component is millimeters. So we stick to one measurement, and instead of using centimeters, we use millimeters because most of the rules use this unit of measurement. So if you see a solid component in a lesion where the largest component has a diameter, that is the largest diameter of less than 7 mm, that is B2. B3 is presence of acoustic shadowing. Acoustic shadowing is a reassuring finding and more typical of a benign lesion. So it's a B3 feature, that is presence of acoustic shadowing within or posterior to an adnexal lesion. Then B4 is if the lesion is smooth, that is, it has smooth inner walls and is multilocular with its largest diameter less than 10 centimeters or 100 millimeters, then it is B4. So multilocular smooth-walled lesion with the largest diameter of less than 100 millimeters or 10 centimeters is B4. And finally, absence of blood flow, that is color score of 1, is a B5 feature. So you can see these are the 5 features which help in predicting benignity in an adnexal lesion. So if you see any one of these features in the absence of malignant features, you can be confident that the adnexal mass is benign. As you can see here, this is example of a unilocular lesion. So B1, unilocular. B2 is presence of a solid component, but you can appreciate here that the solid component has a diameter, that is the largest diameter, less than 7 millimeters. So this is a unilocular solid lesion, but the solid component has the largest diameter of less than 7 millimeters. So it is B2. B3 is presence of acoustic shadowing. So this is the entire lesion, and you can appreciate it has an echogenic component with dense posterior shadowing. There are other mixed echogenicity areas. So this is typical of an ovarian dermoid. Then this is what a multilocular lesion looks like. You see multiple septation, which will be complete in all planes. And if this lesion measures less than 100 millimeters or less than 10 centimeters, as you can see here, it has smooth internal walls. There is no solid component or wall irregularity. So this is what B4 lesion or B4 feature is. And B5 is a lesion which does not have any blood flow or color flow within it. That is a color score of 1. So this is the B5 feature. Now coming to the M rules, or the features which make us think in terms of malignancy. And if you see any one feature in a adnexal mass in the absence of B features, then you can confidently term the lesion as being malignant. So first is M1, that is irregular solid tumor. As you can see here, this is an adnexal mass. It is solid, though it has some cystic areas, but the solid component comprises more than 80% of this lesion. So this is a solid lesion. And if you see in solid lesions, we don't see the inner part or the inner wall. What we see is the outer border. And you can appreciate here this irregularity on the outer border of the lesion. So this is an irregular solid tumor, M1. Then presence of ascites, that is significant fluid. So this is the uterus of a postmenopausal woman. It shows atrophy with mild fluid in the endometrial cavity. And this is the ascites where we can see the freely floating bowel loops. Fluid extends above the level of the uterine fundus and is also present in the utrovesical pouch. This is a part of the urinary bladder. So this is ascites. Then at least 4 papillary structures. So here you can easily see multiple papillary projections. Even if I don't measure, I know that the height of all these lesions is going to be more than 3 millimeters. So they are papillary projections, 1, 2, 3, 4, 5. So more than 4 papillary projections definitely here. This is M3, sorry. Then M4 is irregular multilocular solid tumor with the largest diameter greater than or equal to 10 centimeters. So we agree that this is a multilocular lesion and it has solid component. So it becomes multilocular solid lesion. It is irregular. The irregularity is seen within the inner wall as well as around the outer border. So it is an irregular multilocular solid lesion. And if its size is equal to or more than 10 centimeters, then it satisfies the M4 feature. And if we see very intense vascularity, that is color score of 4, as you see here, that is termed as M5. So if you see any one of these features in an adnexal mass in the absence of B feature, then we can term the mass as being malignant by applying Iota simple rules. So we've moved from simple descriptors to simple rules. However, what happens if you see both B and M features, or if you don't see either B or M features in an adnexal mass? So if you see both B or M features, or you don't see any B or M feature in an adnexal mass, then you cannot use these Iota simple rules, and we need to use other techniques. We can use certain risk prediction models like ADNEX model, or we can refer the patient to an expert examiner who can then try to identify whether the mass is benign or malignant, or we can go in for other investigations. Now, if we use simple descriptors and rules, various studies have found that we can classify nearly 80% of adnexal masses. So even after using descriptors and rules, there will be 20% masses which we'll not be able to characterize, for which we have to resort to other measures, which we will discuss during the course of the presentation. Now let's try to put the knowledge into practice, whatever we've learned so far. So this is an example of a right adnexal mass seen in a 30-year-old lady who presented with pelvic pain, and she had her last menstrual period 2 weeks ago. Now remember, when you're applying or trying to assess an adnexal mass in using Iota terminology, all this terminology, these rules, descriptors, are based on the visualization of adnexal masses by transvaginal high-resolution ultrasound. So whenever you're assessing an adnexal mass, your examination is incomplete unless you have performed both transabdominal and must perform transvaginal scan. As you can see here, these are transvaginal images of the adnexal mass in this 30-year-old lady with pelvic pain. And first, you will describe the appearance of the lesion. So as you can see here, this is a unilocular solid lesion because it has a solid component. We've measured the size of the lesion here. So the lesion measured around 52 into 45 into 46 millimeters. Remember, in Iota, we use millimeters as the unit of measurement. So it's better to stick to millimeters so that we don't end up confusing things when we are seeing the rules. So what we saw was a unilocular solid cyst of size 52 into 45 into 46 millimeters, seen replacing the right ovary with anechoic contents and presence of this single papillary projection. Even if I don't measure it, I know it looks to be more than 3 millimeters in height. And see how the papillary projection has been measured. When we are measuring the height, we have not included the cyst wall. So we take one measurement as the height, the second measurement side to side perpendicular to it. Then we rotate the probe 90 degrees anti-clockwise and take the third measurement side to side. So that's how we measure the papillary projections and get the 3 measurements. Also, we need to look, besides looking at the appearance of the lesion, its contents, the solid component. We measure the solid component. We look for vascularity within the solid component. And you can see that we've switched on color Doppler and there is no vascularity. So the lesion has got a color score of 1. Also, what we look for is presence of acoustic shadowing. So we don't see shadowing either within the solid component or posterior to the lesion. So there is no acoustic shadowing in this lesion. So if we are to try using Iota simple descriptors, we cannot use them because please remember, as I stressed earlier, the simple descriptors, the benign simple descriptors are applicable to unilocular lesions. And this is not a unilocular lesion. It is a unilocular solid lesion. So simple descriptors straight away do not apply to this lesion. Then let's see if we can use the simple rules. And first, as I said, we need not remember the rules, just have a chart next to us. So let's see, B1. Is it unilocular? No, it is unilocular solid. Now it has solid component, but does the solid component have a largest diameter less than 7 millimeters? No, the largest diameter is above 16 millimeters. So B2 also doesn't apply. There is no acoustic shadowing. The lesion is not a multilocular tumor, though it has no blood flow or color score of 1. So B5 feature applies, but none of the other B features apply. And if we were to look at the M features, do we see any features of malignancy? That is it an irregular solid tumor? No, it is not a solid lesion. There is no ascites. There's only one papillary projection. Of course, its size, it's not multilocular solid, and its size is definitely not more than 10 centimeters. It doesn't have very strong blood flow. So only one B feature and no M feature applies. So we can use iota simple rules here because only one, that is B type of features, apply and no M feature. So this appears to be a benign lesion based on iota simple rules. And this lesion was indeed benign. When it was excised, it turned out to be a cyst adenofibroma. So that is how we can use iota simple descriptors and simple rules. But before using them, we must use the correct iota terminology, because if our terminology is not correct, then we will end up making mistakes while applying these rules and descriptors. Now, a typical proforma for describing an adnexal mass using iota terminology should cover the following things. So whenever you see a lesion, you have to see whether it is present on the right or the left adnexa, whether it is unilateral or bilateral. If you see something on one side, don't forget to check the rest of the pelvis carefully. Once you've seen the adnexal lesion, you need to understand whether it is present within the ovary or it is arising or present outside the ovary. Then you need to measure the lesion. Remember to measure it in 3 dimensions, as we've discussed earlier, and calculate volume. If you see normal residual ovary, then you can measure the ovary as well. Sometimes the lesions are so large that they replace the entire ovary, and in those cases, we may not be able to see the ovary separate. This can be mentioned. Then, based on the appearance, you can describe the lesion to be unilocular, unilocular solid, multilocular, multilocular solid, or solid. Then if you see a solid component within a lesion, then you need to again measure that solid component in 3 dimensions. If you see a papillary projection, you need to count. So you must see the lesion entirely from one end to the other in 2 planes and count the number of papillary projections that you see. Don't stop at one, because remember, more the number of papillary projections, higher the chance that the lesion may be malignant. So count all the papillary projections. We need to, again, we can measure the papillary projections in 3 dimensions. We need to have the height of the largest projection at least. If you see multiple, you should at least have the height of the largest projection, because that is used by using certain risk prediction models. Then you need to look for acoustic shadowing. You can see shadowing within the mass. You can see the shadowing posterior to the lesion. You can see shadowing arising from a papillary projection. So again, you must see the solid part of the lesion in multiple planes to look for acoustic shadowing. Then, if you see a cyst, you must describe the echogenicity of its contents, which can be anechoic, ground glass, hemorrhagic, low-level echogenic, or mixed. Then we can switch on color Doppler and subjectively assess the color score ranging from absent to marked vascularity, which is graded as color score 1 to color score 4. And then you look for other features in the pelvis like presence or absence of ascites. Ascites is when the fluid extends above the level of the uterine fundus or into the utrovesical pouch. Now, Iota group initially proposed this 3-step strategy while evaluating an adnexal mass. So first you see an adnexal mass, you describe it as I've done or I've proposed in the proforma in the slide before. And once you've described the mass using standardized iota terminology, first try to apply the benign and malignant simple descriptors. If the simple descriptors do not apply, you move and try to apply the B and M simple rules. Even if those don't apply, then you can either refer the patient to an expert examiner, or now there is an option of using a risk prediction model, that is ADNEX, which can be used, which I will discuss shortly. Now, based on this 3-step strategy, the researchers found that one could classify the adnexal mass as being benign or malignant with a sensitivity of and specificity of more than 90%. So with a high sensitivity and specificity, just by using simple descriptors, simple rules, and finally the examination by an expert examiner, one can have a sensitivity and specificity of more than 90% in characterizing an adnexal mass as being benign or malignant. Please remember, when we see a mass in the adnexa, our first aim is to find out whether the mass is benign or malignant, rather than trying to come at a histopathological diagnosis, because even in the best of hands, a histopathological diagnosis can be proposed in around 50 to 60% of cases. So the final diagnosis comes from pathology. We can try to give some kind of a diagnosis which may turn out to be right in just 50 to 60% of cases. And 40% of cases, we will not be able to propose a histopathological diagnosis. It's enough if we have been able to label the mass as being benign or malignant and then manage the patient accordingly. Then, if you go to the Iota website, these simple rules are available in the form of um, a chart on the website where you can enter whatever you see in the lesion, and it can help you in calculating what is the likelihood of lesion being benign or malignant. As you can see, I have entered certain features. So since there was no B feature in my adnexal mass and presence of these two malignant or M features, the software has calculated that the risk of malignancy using the simple rules in the adnexal mass that I've entered is pretty high, to the tune of 89%, nearly 90%. So if you want, you can go to the website and use this, or you can just have this printout next to you whenever you are assessing an adnexal mass and see which features are present, which are absent, and then conclude whether the mass is benign or malignant using Iota simple rules. Now, if Iota simple descriptors and simple rules do not apply, what can be done next is use the ADNEX model. As I said earlier, ADNEX is available on the web browser. It can be available or used as an app on your smartphones and is also incorporated in some ultrasound machines. ADNEX stands for Assessment of Different Neoplasias in the Adnexa, and it uses the following variables: the age of patient, type of center where the patient is being evaluated, that is whether it's a gynecological clinic or an oncology setup, serum CA-125 levels, if they are available. Even if they are not available, the ADNEX can still calculate the risk of benign versus malignancy without serum CA-125 being entered, and it uses 6 ultrasound variables. So by applying the ADNEX model, one can characterize or understand whether the mass is benign or malignant, and also it gives the risk of the various kinds of pathologies, whether the mass can be a borderline ovarian tumor, whether it can be a stage 1 ovarian cancer, or a metastasis to the ovary. So it can not only help in differentiating benign from malignant, but also give an idea as to what type of tumor we can see in the adnexa. The 6 ultrasound variables that we need to enter in the ADNEX model are: number 1, the maximum diameter of the adnexal lesion, which is again measured in millimeters. Then the solid component of the lesion, we need to measure the maximum diameter of the solid component of the lesion, as we've done here. Again, the measurement is to be entered in millimeters. Then if you see a cyst with locules, you have to answer whether there are more than 10 cyst locules or not. That is yes or no. Because more the number of locules, higher the chance that the lesion is malignant. Then, as I said earlier, if you see papillary projections, you have to accurately count the total number of papillary projections, because in ADNEX you have to enter if there are no 1, 2, 3 or more than 3 papillary projections. Then if you see solid component, you have to look for acoustic shadowing. As we can see here, this is a papillary projection, and we can appreciate posterior acoustic shadowing behind the papillary projection. So you have to enter whether there is acoustic shadowing or not, because as I said again earlier, acoustic shadowing is more indicative of benignity of a lesion and presence of ascites. As you can see here, this is the uterus, atrophied uterus over distended urinary bladder, and significant ascites in the pelvis. So whether there is ascites or not. The 6 ultrasound variables will be the maximum diameter of the lesion, maximum diameter of the solid component of the lesion, more than 10 cyst locules, yes or no, the number of papillary projections, acoustic shadowing present or not, and finally ascites present or not. This is what the web application of Iota ADNEX model looks like. As I said earlier, we'll enter the age of the patient in years. We'll enter the center where she's being seen, whether it is a gynecological oncology setup. In this case, it wasn't. Then what is the maximum diameter of the lesion to be entered in millimeters? So this is 8.9 or 8 centimeters or 89 millimeters. So always measure in millimeters when you're using this Iota simple rules or ADNEX. Then you see the maximum diameter of the largest solid part. It's around 40 millimeters. More than 10 locules, no. Number of papillary projections, more than 3. Acoustic shadowing, no. Ascites, no. And serum CA125. Remember, even if you don't have the serum CA125 at the time of performing the scan, you can still get a risk with ADNEX. You press calculate, and this is what the ADNEX gives you. Now, you can see here that the chance of this lesion being a benign tumor is 27.6, whereas that being malignant is very high, 72.4. So the lesion that we dealt with, or whose parameters that we've entered in the ADNEX model, is most likely malignant. Now, once we've identified malignancy, what type of malignancy it is also provided by the ADNEX. As you can see here, ADNEX can give you an idea whether the lesion is likely to be a borderline ovarian tumor, a stage 1 ovarian cancer, a stage 2 to 4 ovarian cancer, or a metastatic tumor. So it gives you a patient-specific risk, so you can get an individualized risk not only for whether the lesion is benign or malignant, but also regarding what type of tumor it can be. So we can see that there is all more than 20% or 25% chance that the lesion can either be a borderline ovarian or a stage 1 ovarian cancer. Now we'll take a pause here. We've gone through a lot, that is Iota terms and definitions, simple descriptors, simple rules, and the ADNEX model today. So we'll take a pause and then move on to the rest of the presentation. Let us try to recapitulate and see if we have assimilated what I discussed in the previous slides. So here are a few exercises for you. Now, what type of lesion do you see in this image? Please have a look at this image carefully, and you can post your answers either in the WhatsApp group or even on this channel as to what you think that this lesion is. Is it unilocular solid, multilocular solid, or solid, based on the Iota terminology? Example of another lesion, another adnexal lesion. It's actually a clip which I'll play for you. Please have a look at this clip carefully. And based on the appearance of this lesion or the morphology of the lesion, you have to describe the appearance, whether this lesion is unilocular, unilocular solid, multilocular, or multilocular solid. And the third exercise, again, it is a clip. This is a lesion which measures 65 into 60 into 55 millimeters. Look at the lesion carefully and please let me know as to whether it is likely to be benign or malignant. I'm scanning the lesion from one end to the other so that you can see it in its entirety. So you would have to use the Iota terms and definitions, simple rules, descriptors, and then come to a conclusion as to whether this lesion is benign or malignant. The lesion measures 65 into 60 into 55 millimeters. Its largest solid component, that is the papillary projection, measures 15 into 11 into 10 millimeters. And I can tell you that there was no ascites seen in this patient.